awards, including the Young Neurosurgeon Award and APJ Abdul Kalam Inspiration Award, and with multiple publications. Today he'll be sharing insights on a very timely and vital subject, cracking the code, new frontiers in head trauma care.
Good morning, everyone. Today, I'm going to crack the code for you all. I would be presenting the recent advances, updates, and technological innovations in the management of traumatic brain injury or head injury. Let's start. Basically, what is traumatic brain injury? It can be defined as the disruption in brain function or other evidence of brain pathology which is caused by any external physical force. It accounts to decrease in consciousness levels, seizures, or even decrease in the cognition level, or even slowness also, following a traumatic event or external physical force. Globally, it is surprising to know that around 70 million people are affected by traumatic brain injury, and it accounts for one of the major cause of death and disability even in young individuals. Traumatic brain injury is a heterogeneous entity, and it can be classified based on Glasgow Coma Scale. Till Glasgow Coma Scale has been invented by Professor Jennett and Teasdale from University of Glasgow, patients has been described as stupor, comatose, semi-coma, delirious, and in a vague manner. So there has been a need for inventing Glasgow Coma Scale to define the patient, to define the clinical patient, and it has become a clinical common language throughout the world by neurologists and neurosurgeons, by any practitioner, to define the clinical neurological status of the patient. Mild accounts for 14 and 15 GCS, moderate 9 to 13, and severe 3 to 8. The simple concept of primary and secondary injury, primary and secondary traumatic brain injury, which arose a couple of years ago, around 30 years ago, by identifying that secondary injuries like hypoxia and hypotension leads to increase in exacerbation of primary injury. So there has been need to define the protocols as first and second. First and foremost are the pre-hospital protocols in maintaining airway protection, systemic oxygenation, adequate perfusion, and other secondary monitoring methods like ICP monitoring, brain multimodality monitoring, and brain tissue oxygenation monitoring, and other cerebral microdialysis, and the role of seizure prophylaxis and biomarkers in therapeutic hypothermia. Today, I would be discussing three major arenas of recent advances in the management of traumatic brain injury. One is monitoring protocolized therapies in the neurocritical care unit, and second is the role of decompressive craniectomy, and the third is novel pharmacological therapies. As we all are aware, the first and foremost is the role of intracranial pressure monitoring in the clinical management of severe traumatic brain injury, because we know that raised ICP leads to decreased cerebral perfusion. Decreased cerebral perfusion leads to hypoxia and accumulation of lactic acids and cerebral edema, and it causes even death. So the Brain Trauma Foundation guidelines, which was given in the fourth edition, which was given in 2016, has advised ICP monitoring in all the patients who with a GCS score of less than or equal to 8 with an abnormal CT, or even in high risk patients with normal CT also, to monitor ICP. In this is a simple picture of monitoring of ICP, where till now the gold standard method of monitoring intracranial pressure is by putting an EBD and measuring the intracranial pressure. Coming to second part is the brain multimodality monitoring. It is the use of multiple overlapping monitors to detect early detection of physiological derangements. The two most common widely used monitoring methods are brain tissue oxygenation monitor and microdialysis monitors. In this picture, we can see a simple Clark electrode is inserted into the brain parenchyma by putting a small burr hole, which has 3 channels, like to measure the ICP or to measure the brain tissue oxygenation and for cerebral microdialysis. The concept of brain tissue oxygenation has arose few years ago, because when patients are being therapeutically hyperventilated in order to decrease the ICP, there is decrease in the brain tissue oxygenation, which is leading to hypoxia and further which is causing secondary damage. So there is a need for monitoring of brain tissue oxygenation by certain probes, and which will increase which will detect the hypoxia, and so that we can increase the increase the oxygen support and also decrease the hyperventilation. Few trials like Boost 2 trial has observed the role of the need for brain tissue oxygenation in clinical practice. And second is cerebral microdialysis, where a simple catheter is inserted into the brain parenchyma with a semi-permeable membrane, which measures the metabolites like glucose, pyruvate, lactate in the extracellular fluid, and it detects at a hourly level, hourly basis, and it will give us input immediately where there is derangement of metabolites, we can correct immediately. Coming to additional monitoring tools like thermal diffusion flowmetry and near infrared spectroscopy are needed to measure the cerebral perfusion. These are simple electrodes, simple probes which are placed on the frontal region, and these are helpful in measuring the cerebral perfusion. Next, coming to the role of seizure prophylaxis. The Brain Trauma Foundation guidelines has reinstated the role of post-traumatic seizure prophylaxis with either phenytoin or levetiracetam within 7 days of injury, because Brain Trauma Foundation has observed that the incidence of clinical post-traumatic seizures is as high as 12% in clinical and as high as up to 20 to 25% in subclinical seizures. But it is to be kept in mind that this is a level 2A recommendation, not level 1. And coming to biomarkers, this is the most important facet of whole realm of advances in the post-traumatic brain injury. Why? Because till date, all the neurosurgeons or neurologists or intensivists are dependent on either clinical examination or imaging by CT or MRI to identify whether the patients need surgery, or whether to prognosticate, or whether to predict the advancement of course of disease, or whether to quantify the brain injury. These biomarkers act as a surrogate markers in a detectable, in a reliable manner in the peripheral blood to quantify the brain injury. These biomarkers are nothing but simple proteins or chemicals released into the peripheral blood on disruption of the blood-brain barrier. There are many biomarkers, but the most common one are glial-related biomarkers like GFAP or S100B, and neuron-specific enolase, ubiquitin, amyloid protein, tau protein, and others. The major disadvantage of these biomarkers are these are detected in the peripheral blood only once the blood-brain barrier are disrupted, which is not seen in many mild traumatic brain injuries. However, we are not interested in mild traumatic brain injuries. We are interested in moderate and severe traumatic brain injuries, where there is almost definitive disruption of blood-brain barrier, and the release of and the presence of these biomarkers are identified in the peripheral blood in serum. S100B ticks all the boxes for clinical practice, for the clinical detection of S100B as a clinical practice in head injury as a biomarker. It is present in astroglial cells. As we all are aware, astroglial cells are repair cells of the brain. Whenever a brain sustains an injury, astroglial cells are activated, which goes to the nearby area where the injury is there. It will start repairing the brain. Once the astroglial cells secretes the S100B protein into the CSF, it gets leaked into the peripheral blood, which is detected in the peripheral blood, and we can measure the S100B to identify, to quantify, to detect, to prognosticate the outcome of the patient. And one more important aspect of the S100B protein is it is detected immediately within few hours after the injury, and it has a very short half-life of less than 24 hours. So it can be measured on a regular basis in patients without subjecting the patient to ionizing radiation by shifting the patient to CT scan and on a regular basis. However, the role of CT scan cannot be underrated. Other proteins like GFAP and the neuron-specific enolase are there, which can also act as a biomarkers. But however, there are certain disadvantages as they have very short half-life of less than 6 hours only. And coming to therapeutic hypothermia, it is a very controversial thing. Some studies which were done like Eurotherm and hypothermia RCT has proven that there is no role for therapeutic hypothermia. In fact, there is paradoxical effect. There is increased mortality in patients who were therapeutically made hypothermia. And coming to the role of decompressive craniectomy, it is method of removing a substantial portion of skull vault to reduce ICP and reduce the consequent deleterious secondary sequelae. It can be primary or secondary. There are two important trials which studied the role of decompressive craniectomy. One is DECRA and second is rescue ICP trial. The DECRA trial had not shown any significant benefit in mortality or functional outcome. However, the second trial, rescue ICP trial, which was a larger trial than DECRA trial, had showed that there is significant decrease in mortality at the risk of prolonged vegetative state and severe disability. And coming to pharmacological innovations, corticosteroids, no, there is no role. However, and in fact, it has a paradoxical effect. There is increased death in patients who were given corticosteroids. And the role of progesterone has been studied by few trials like PROTECT 3. There is no benefit in giving progesterone immediately after head injury. However, the role of erythropoietin has been studied. It has showed significant reduction in mortality, but it has not yet the clinical trials are only over, but the clinical guidelines are not yet out. And the role of amantadine, which works as NMDA antagonist and indirect dopamine agonist, has been studied. There is no significant improvement in cognition or outcome. And the role of tranexamic acid has been studied, which is an anti-fibrinolytic agent to reduce active bleeding. CRASH-2 trial has showed decrease in significant mortality rate when patients are given tranexamic acid immediately after injury, that is within 6 hours. And the role of citicoline has been studied, but there is not much benefit by giving citicoline in few studies, but few studies has showed a slight improvement in cognition and functional status after 90 days. And other anti-inflammatory therapies like recombinant interleukin-1 receptor antagonist has been studied, which showed some slight positive benefit. Coming to the role of artificial intelligence, no talk or no speech would be complete without mentioning the role of artificial intelligence nowadays. Can anyone identify who is this gentleman, American scientist? All the AI apps, you name ChatGPT, Alexa, or Perplexity, or Gemini, all the AI apps, all the algorithms are written based on the simple statement given by this person, who is John McCarthy. He is the father of artificial intelligence. He has a wonderful thought a couple of decades ago: why can't machines be taught like human beings? When human beings can be taught to think in a way, why can't machines be taught like that? His initial experiment is a simple teapot. When to switch off the teapot or when to switch on the teapot, a simple teapot which was kept on an induction stove has been studied by this gentleman. And this statement, where the artificial intelligence is the science of making machines do things that would require intelligence if done by people. This statement is the basis of writing all the algorithms of AI apps which we are using right now. The role of AI in medical research, that too in traumatic brain injury, has 3 limbs. One is in diagnosis, like biomarkers, MRI and CT, and second is prediction, like models, crash model and impact model, and in rehabilitation, cognitive, physical and personalized. And AI helps in interpreting X-rays, CTs and MRIs, and also it can predict in risks, outbreaks and patient deterioration in real time in ICUs, and also it can help deliver drug designs and in clinical trials. And in Western countries or European countries where the hospitals are state funded, there is a responsibility on the doctors, on the surgeons or neurosurgeon to predict when the patient is having poor prognosis and not to put funds more on those patients. So these models has evolved. Crash and impact are softwares where we feed certain data to the softwares like GCS score, age and pupillar reactions and CT findings. And these models will give a prediction of the outcome and which can be substantiated in the court of law, and it can help the surgeons to put efforts or funds over those patients. And coming to other aspects like cognitive impairments, certain softwares like InCog 2.0 and motor dysfunction and exercise programs are tailored according to the patient for rehabilitation and programs. And coming to other aspects like rehabilitation, there where the patients are where the patients are having cognitive decline or speech defects or language therapies, certain AI softwares which can be tailored according to the patient deficits, where the need for pitching the deficits is very easy in AI programs. And these are and the others are exoskeleton. This is where a thought meets innovation. This is the first US FDA approved exoskeleton called Rewalk. Imagining having all the money in the world, having all the knowledge at your disposal, having all the resources, but you meet with a simple accident and you can never walk forever in your life. But having the boon of AI, these exoskeletons, with these exoskeletons, the patient can be able to stand on their own. Not only stand on their own, they can be able to walk around, roam around, and they can be independent, not being dependent on anyone else for simple ambulation or dependent on being on nursing care or other person for roaming around. This US FDA approved exoskeleton costs around 65 to 85,000 US dollars. This is the another model called Emixon. So this patient who was bedridden for a couple of decades, he was restricted to his couch, seeing nothing but his ceiling. But with the help of this AI-driven exoskeleton, he is able to walk again and roam around with, and the rehabilitation is also increased. It boosts the patient confidence as well. Thank you.